My name is Nick Cavino. I'm the president at William James College, and welcome to our forum this morning, Innovative Approaches to Building and Sustaining Culturally Diverse Behavioral Workforce. This is the third forum that we've done on this topic in the last several years. We've been very fortunate to have close partnership with HRSA, and in particular, Captain Chris Bersani, who is the Deputy Regional Administrator and the National Lead in Behavioral Health at HRSA, who is also a clinical psychologist. Today's effort is also co-sponsored by the Blue Cross Blue Shield of Massachusetts Foundation, and it's represented by its president, Ms. Audrey Shelto, who's a longtime advocate for behavioral health and an expert on healthcare policy. I'll ask them to add a word of welcome in a minute. Let me just say, look around you and hi, Andy. Good morning. Andy gets a special welcome whenever Andy's in the room. So good morning, Andy Pond from JRI. Look around the room, though, and see the folks that have gathered here are experts in a variety of places in behavioral health care. Your senior executives, your administrators, your academics, your policymakers, your foundation and research experts, and your advocates. And you know that during this pandemic, the usual 18% of folks who are experiencing significant problems with anxiety, depression, substance use disorders is now close to 40% of our population. Coming out of this at the other end, we'll see the after effects of what happens when 25% of our adolescents are experiencing suicidal ideation. So we're in this very peculiar space. We know that we're in this very peculiar space where we're seeing the end of almost a year's worth of confinement and terror for many people, but certainly significant losses and threats from a pandemic coming to an end or coming to a close end with the vaccines online. But we're going to see a second wave of this tsunami when we see the sequelae of our kids not having been socialized for almost a year, where we see folks that have lost people in large numbers coming back into our lives and in our world, where we see the after effects of significant seeds sown of mistrust of each other. So the work that we do and the commitment that we have to building a culturally responsive behavioral health workforce could not be more important than it is at the moment, could not be more important. We know that there's a great need for us to attract and support folks of color into this workforce. 90% of people largely who work in this field, look around even at who we are as we've gathered here today, 90% of the folks that deliver care are non-Latino Caucasian folks. We need to be thinking about creative ways to attract and support people into our field that have a lived experience with the folks that we serve. And so this forum is our effort to say, let's twice a year, 3 times if we can do it, but certainly twice a year if we can do it, let's bring the experts into the room and let's not have an ain't it awful discussion with each other, but let's think together about what we're doing to bring some solutions and some initiatives that are creative to the problem. Let's share them with each other so that we can copy from each other. Let's share them with each other so that we can help each other to grow and develop and improve on the ideas and initiatives that we have. Let's find a way that we can say that together collectively, we're building the diverse workforce that our country needs. So I'm very grateful to you all for joining us. I'm very, very grateful to the panelists that came forward. We asked people at some pretty high levels doing some pretty important research and clinical work to join us as leaders today, and people said yes almost immediately. So I'm very, very grateful to you for your generosity and your responsiveness. Let me ask my colleagues if they would just say a word of welcome. So we'll go with President Shelto. Audrey, would you just start first, and then we'll have Chris.
Sure, happy to go. I like that, President Shelto.
That's what I was thinking.
Thanks, Nick, and I'm so happy to be involved in this session. And for those of you who don't know me, my name's Audrey Shelton. I'm the president of the Blue Cross Blue Shield of Massachusetts Foundation, and we focus on access to healthcare for low-income and vulnerable populations. And one of our major focus areas is behavioral health, in no small part because while you remember when there was a point in your career where it would be good to say, over 10 years of experience in blah, blah, or over 20 years. Well, I just realized that I've gotten to the point where I do not want to say the number because it is not a pretty number. So, but it has been a long time since I started an undergraduate degree in psychology and then moving to Boston and working in a community-based mental health program where we had a number of group homes and what was then called a sheltered workshop for hundreds of people who had recently been deinstitutionalized from the state hospitals. And behavioral health, mental health primarily, but also some in substance use disorder has been the common theme throughout my almost many decades of work here in the greater Boston area. So it's access to mental health services, behavioral health services has been a passion and a pain point for me throughout my career. And it's always been a problem, as we know, here in Massachusetts, as well as elsewhere in the country. And whenever we'd work on access issues, whether it was something, whether we're out in the community talking about outpatient mental health or substance use disorder treatment, or we're talking about intensive inpatient care, workforce would always come up. Workforce. Lack of capacity in the community, beds that are sitting empty in inpatient facilities because we don't have the staff to open them up. So it's always been a critical issue, workforce. And now with the pandemic hitting us and our recognition of the racial inequities associated with the pandemic, which really we've just highlighted those. I mean, these racial inequities are certainly not true. I mean, I'm sorry, certainly not recent. They've been true forever. We're just, the workforce issues are just so much more complex. We need not only to get more people into the field, we need to get more diversity in the people coming into the field, but we really need to think differently about workforce. It's not, we need to think more about team-based care. We need to think about having both clinically trained, credentialed people, as well as, people with lived experience, community health workers, peer supports, recovery coaches, et cetera. So I think we're at an exciting time in terms of thinking about the behavioral health workforce, but it's complex. And we have to really, I think, as Nick was saying, think together creatively about solutions, because the crisis of the pandemic and the recognition of longstanding racial inequities and how nearly impossible it is to find a therapist who looks like you if you don't look like me, are just, we can't not work even harder on trying to fix these problems. They're so critical. So thank you all for joining us today. I'm really excited about today's sessions and look forward to the discussion. And it's so great to see so many friends on this screen as well. Joe Feaster.
So who does not know Joe Feaster, right? So thank you for making time for us today. We hope someone's attending to your law practice while you're here with us doing mental health.
I figured you would hire me, Nick. That's why.
It would be my pleasure, Joe. People say there's no healthcare without mental health. We also know, those of us in the screens, there's no mental health care or behavioral health care without a workforce. That's a big rate limiting step. And HRSA has taken the lead in finding ways to bring that workforce forward. We've not had a better ally in that in New England, in this region, than Dr. Chris Bersani. So Chris, do you want to just add a few words of welcome to the group? You need to unmute yourself. Chris, you need to unmute yourself. Chris. So Chris, there you go.
I am unmuted. Can you hear me now?
Yeah, we're good. Thank you.
My phone, can you guys hear me?
Yeah, it's perfectly fine now. The feedback's gone.
Okay, I cannot hear you, so I'm assuming you can hear me?
Yes.
Okay, good. All right. I was going to use the phone today because I've been getting some feedback that my microphone is not working so well on my computer, but the phone did not work out. So here we go. So hopefully you can hear me okay. I'm going to spare you my standard speech about HRSA and all the great things that we do as an agency, but I do have a request, and that is to take a few minutes, please, and check out HRSA's website. It's easy to find. It's hrsa.gov. The website is rich with well-established and very new and interesting funding opportunities for healthcare, behavioral health, substance use treatment, as well as loans and scholarships. So please, please take a look and see how HRSA might benefit you or your organization. There are some great opportunities out there right now. So to kick off today's event, I just wanted to share with you some findings from a previous workforce event that our office, the Regional Office of Regional Operations within HRSA, hosted with the William James College. It was an event entitled Help Wanted, Preparing and Strengthening the Behavioral Health Workforce. This symposium occurred on May 3rd, 2019 at the William James College. Boy, that seems like a different lifetime right now. But actually it was only 18 months ago. So the event had over 50 selected participants considered to be leaders in the field of behavioral health, including substance use treatment. What I wanted to share with you today were a few cross-cutting themes from the breakout sessions that occurred that day. Indeed, there are some real gems in these takeaways from people with years of experience in leadership roles whose opinions are so valuable that reflection on these suggestions in conjunction with today's discussion on the topic of diversity will assist us in moving the dial on this issue. Time does not allow me to review all of those findings now, but I'm going to share a few of these, and I'm going to send a summary document to Dr. St. Louis and Dr. Covino so that they can share them with all of you, okay? So let me just tell you some of the key themes that we talked about that day, and these were the themes that we identified previously that we had gotten feedback were the most important things to talk about with regard to workforce. We covered preclinical and pre-service educational needs of the workforce, improving public perception of careers in behavioral health. We discussed the development of clear career ladders for people in the field. We talked about compensation. We talked about staff training, supervision, and professional development. We talked about how the publicly funded system can be used as a training ground and how it can be more effective as a training ground. And we talked about the role that funders and payers play with regard to recruitment and retention of providers. And finally, and of course, most importantly today, we talked about diversity. And with regard to diversity, participants reflected that they struggle to recruit and retain staff with the cultural backgrounds and or the language skills that match their service population. Participants identified the need for mentorship and an active commitment to helping people who are new, particularly people of color. The participants that day suggested incentives to attract a diverse workforce and people of color, creating intentional plans at the agency level to recruit people of diverse backgrounds. Agencies need to examine and adjust their organization's culture, policies, and practices, allocation of resources, and leadership to be more welcoming and better reflect the diverse workforce. Participants also discussed improving the number of people in recovery entering and staying in the field. Some participants indicated that the field was not attuned to employing people in recovery, and that many organizations are not taking into consideration issues of recovery when it comes to supervision, which of course is very important with retention. Participants noted that there is a need to consider how leadership in organizations prepare their existing staff for a peer workforce. So those with experience integrating peers into an existing organization noted that there were a lot of staff who were not prepared to work with peers. So this requires planning and thought to integrate professional staff with peer staff in a way that everyone feels valued. Okay, so that's just a sampling of some of the opinions and ideas rendered by participants at the symposium. But I hope that those ideas, combined with today's panel sessions, can bring us closer to achieving the robust and diverse behavioral health workforce we all know is so crucial to delivering the services we provide in an effective and meaningful way. And with that, I want to thank all of you for participating today. I want to thank the William James College and Blue Cross Blue Shield for their commitment to a diverse workforce. And I'll send it back to you, Dr. St. Louis.
So before it goes to Dr. St. Louis, let me take a minute to thank Dr. St. Louis. So Jemima is one of the college's vice presidents. Her oversight is around our workforce development programming. We've a number of such specialty programming at the college. You hopefully know about this. I am particularly blessed because Jemima took this conference and said, well, I'll help pull this together and that together and this together and that together. And she's not only created a wonderful program for us, she literally created a wonderful program for us. So there is a book that I'd encourage you to go and look at that describes our speakers, lets you know a bit about who's in the room, gives you some helpful links, directs you to some reading materials that we can share. And then our hope is that we will build on a micro website and share materials with each other and be able to direct ourselves to a host of information. But I'm looking again around the room. I see Mr. Wings in the room. I'm looking, Joan Wallace Benjamin's in the room. We've got folks from a lot of different places. And again, I want to underscore as we move into our program, part of the aim and what we're doing with this day is to bring folks together to talk about an issue that has escaped solution for too many years that now we're putting our energies into. And so I'm very grateful to all of you for your time and for the energy that you devote to this, and welcome to our collaborative effort for today. Dr. St. Louis, would you like to take over? Yes, you would.
Good morning, everyone, and thank you, Dr. Covino, Dr. Bersani, and Ms. Shelto. On behalf of the college, I would like to welcome all of you. I'm Jemima St. Louis. I'm an associate professor in the clinical psychology department at William James College, and also the associate vice president for workforce initiatives and specialty training. We have put together a very rich agenda for you today, and in a moment, I will be introducing our keynote speaker. But first, just wanted to provide you with some guidelines regarding how the day is structured. Dr. Angela Beck will begin with a keynote keynote presentation rather, which will be followed by a panel presentation on successful career ladder models in the behavioral health field. We will take a break around 11 a.m. to allow you to get up and stretch. And when we come back, we will have the opportunity to hear from Mr. Mark Abelard, Dr. Jenny D'Olympia, and 3 of our talented students who are part of the first cohort of the Behavioral Health Search Core. We will also have 2 breakout sessions later on this afternoon. As you will see in your agenda, we will be asking you to please let us know by utilizing the chat which of the 2 panels that you would like to participate in today. The first panel will be geared toward attendees who have an interest in hearing more from service providers and community-based organizations in terms of their workforce development initiatives. The second panel would focus more on social policies, program development, and for those who have an interest in hearing more from our partner organizations that are mostly involved in policies, we would encourage you to sign up for panel number 2. So please have a moment, if you haven't had a chance to click on the link that Rebecca Drew has put in the chart. This is a microsite that Ann Wilson has created, and as Dr. Covino mentioned, this is where we will have copies of all the PowerPoint presentations that will be discussed today. So feel free to browse through the website so that you can also download a copy of the agenda. Lastly, for those of you who are interested in seeking continuing education credits, we will send a survey at the end of today's forum. We will put the link also in the chat so that you can download it. I think this is all for logistical details. And now it is with great pleasure that I introduce our keynote speaker, Dr. Angela Beck, who is a clinical assistant professor of health, behavior, and health education, and also an associate dean for student engagement and practice at the University of Michigan School of Public Health. In the interest of time, I would invite you to read her comprehensive biography in the agenda that's attached. Dr. Beck, thank you so much for joining us. The floor is yours.
All right, wonderful. Good morning, and thank you for the kind invitation to join you today. Let me just get my slides pulled up here. I couldn't agree more with all of the comments shared at the opening. And I'm just so glad to be part of an event that's highlighting the really critical challenges that we face in behavioral health around workforce development and building a workforce pipeline that can really start to address the longstanding shortfalls that we've seen in behavioral health workforce capacity, but also showcase some promising practices and solutions. What I would like to do in the next 30 minutes or so is give a bit of background on the status of the behavioral health workforce, and in fact, some of the difficulty that we have in providing a comprehensive national picture of that. I'll also touch on some of the work our center is doing around workforce development policies and programs, and I actually will mention some of the good things that HRSA is doing in workforce development, even though Chris didn't have time to do so. But first, want to quickly introduce you to the Behavioral Health Workforce Research Center. I've had the privilege of directing this team of interdisciplinary researchers since our center was established at the University of Michigan School of Public Health about 5 years ago. We are HRSA funded. We are part of the Health Workforce Research Center network. That network includes universities across the country that have different areas of health workforce that they research, health equity, long-term care, oral health, and so on. At the University of Michigan, our focus is behavioral health. So looking at the workforce contributing to prevention and treatment of mental health and substance use disorders. We accomplish this through a consortium model. So the U of M is really the research infrastructure for the center, but we have this wonderful group of partners on our consortium that represent different disciplines within behavioral health and different sectors of the field. And this is the group that we rely on to help frame our work plan each year. I am not a behavioral health specialist by training. I'm trained in health workforce research. So having guidance from groups that represent the various components of behavioral health is really critical to our success. With feedback from the consortium, we structure our research projects around priority theme areas that are also identified jointly with HRSA. The 6 core themes that underlie our research are listed here. So we conduct research to help inform solutions for workforce shortage and maldistribution. We need to understand the characteristics and the practice settings of the workforce, as well as mechanisms for strengthening the workforce and engaging in workforce development. And we know that there are systems issues such as scope of practice, service delivery and reimbursement policies that affect workforce capacity. And evidence-based strategies require good data. So our center has also done some work on looking at workforce data sources, data quality, and advising on minimum data sets for the field. We've conducted over 50 studies across those themes in our 5 years, and I would say the portfolio of our work is really collectively trying to answer this question. How do we build workforce capacity to ensure continuous and equitable access to quality behavioral health care? So with that, I'll start with an overview of the state of the behavioral health workforce, looking a little bit at supply, demand, and distribution. We're thinking about the workforce broadly, inclusive of its many occupations, levels of training, varied scopes of practice and authority, and functions. I would say research efforts have traditionally focused on the core licensed professionals, and our center is certainly working to expand that. And although we generally know that there are workforce supply and distribution challenges in behavioral health, the lack of systematic data collection nationally makes shortage difficult to determine in a quantitatively precise way. I always start with kind of setting what the definition is of behavioral health workforce that I'm talking about, because we see different definitions commonly throughout the field. Certainly, these licensed professionals are part of the workforce that we study. They tend to drive the bulk of the workforce research. Certified professionals also critical to behavioral health service delivery. You see addiction counselors listed in both categories there, as they could be either licensed or certified depending on the state and on their training. And we certainly don't want to leave out our primary care providers who are providing substantive behavioral health services, especially in areas that are lacking a behavioral health provider. When we think about the supply side of the workforce, the fundamental question of how many workers do we have is often asked. And while a very reasonable question, the answer is actually not so straightforward. Workforce estimates generated for behavioral health providers vary depending on the data source, and that's because each data source has different definitions and different inclusion criteria for who they're counting within that enumeration. And this table just kind of gives you a very brief example of that. So let's look at the second row of providers here, so clinical psychologists. The first column of data coming from the Bureau of Labor Statistics suggests that we have about 113,000 clinical psychologists in 2018. And when you look at a different BLS data source from a year later, we see an enumeration of closer to 192,000 clinical psychologists. And then, you look at the other sources column there on the end, and you see the APA and some other government-supported research enumerated psychologists to be between 102,000 or 187,000 in number in around the same time period. So the methods for all of these studies are substantively different. Some rely on membership data, some use NPI data, some include a broader workforce than is actively practicing in behavioral health. So you can imagine trying to piece together a national estimate of workforce supply for behavioral health, given the lack of a uniform data system. It's pretty challenging. But we can group the data with the most similar methods and inclusion criteria for at least some of the workforce. It's usually the licensed occupations, which is why they're so much more prominent in the workforce. And here we can see the relative size of the workforce for these occupational classifications. Now, a few of these bars represent different types of social workers, so different classifications of social workers. But in total, this estimate of just these occupations within the behavioral health workforce show over 1.1 million workers on a national scale. So the supply side can be tricky, but that's actually an easier estimate than talking about workforce demand in behavioral health. HRSA's National Center for Health Workforce Analysis uses a pretty sophisticated simulation model to project supply and demand for lots of segments of the health workforce, behavioral health included. This table is showing you projections for 10 years from now. So it's starting at 2017 and trying to project out what the workforce might look like in 2030. And here's what the simulation model thinks we'll see for supply versus demand. In this red box under supply, we see that the projected numbers in 2030 for these selected occupations total around 1.2 million workers. And that represents supply growth for all of the occupations that they've listed, except for adult psychiatrists over here. So according to this model, we should expect a healthier workforce pipeline for these occupations and relative growth compared to the estimated 2017 supply. So now let's look at demand in the blue box down here. Demand is often estimated from a calculation that's based on service utilization and sometimes based on unmet need for behavioral health services. Each of those calculations or those variables have some limitations with regard to how accurately we can estimate that. This projection model suggests that demand will grow through 2030 for all of the professions except for child and adolescent psychiatrists, with total workforce demand estimated to be about 868,000. So overall, this model is suggesting a little bit of surplus actually just for these behavioral health occupations by 2030 for most of that workforce, aside from psychiatrists and addiction counselors, if no changes in behavioral health utilization occur. So on the surface, that might sound like maybe some good news, that perhaps it's a counter to some concerns about workforce shortage that we often hear. Here are some considerations to keep in mind. We have a really tough time estimating unmet need. So people who are untreated either due to lack of access to services or because they're not seeking services, that's hard for us to account for. The supply numbers are imperfect, so the numbers being used by the simulation model are subject to the same limitations that I just talked about with regard to supply. In particular for this study, I know there is a notable overestimate of social workers because we just simply can't get granular enough data to tell how many are actively working in behavioral health, such a broad field. We should interpret these numbers, I would say, pretty cautiously. Methodologic limitations mean simulation models can give you a signal as to where the field may be going. The results are not sensitive, though, to changes in care models or other factors that are impacting workforce capacity. We just heard about some of those in the opening remarks. So what's happening on the ground matters, and we shouldn't discount that just because we can't quantify it. And importantly, surplus does not mean too many. So we need to get out of a mindset of provider per population ratios when we're talking about care delivery, and think about how providers contribute to care teams, fulfilling various different roles. And I would say that's not just for behavioral health, but in all health workforce studies. This workforce is very much needed. So in summary, I would say the information that we have available to us about supply and demand might look potentially promising, but I don't think we have enough refined data here to go so far as to declare that we're hopeful for the end of our workforce challenges within the next 10 years. But it does give you some kind of sense of what comparisons of these projections might look like going forward. I hope also it gives you some sense of the challenge we have in trying to get an accurate estimate of the state of the behavioral health workforce with regard to supply and demand. So here's another piece that simulation modeling isn't accounting for, and that's workforce distribution. We know certainly that workforce capacity is not just a headcount issue. The workforce is not equitably distributed among the population, and that has real consequences related to access to care. This map from a few months ago gives you a sense of the severity of the maldistribution. It's showing mental health HPSAs, so health professional shortage areas, this is specific to mental health. The darkest colored counties represent areas where the whole county is a shortage area. The lightest colored areas are counties with no shortage area at all. And then there's some in between where part of the county is a shortage area. So you can see we've got some pockets of lighter shaded counties in the Northeast, some in the Southwest, and some around some metropolitan areas. But shortage across the country is quite obvious here, right? Most of this map is very dark blue. There are over 5,700 mental health HPSAs across the country, and we need nearly 6,500 practitioners to remove that HPSA designation. And this number has been exponentially increasing for several years. By practitioners, we typically mean psychiatrists when we're talking about mental health HPSAs. So this is not a measure that looks broadly at the available workforce. Nearly 2/3 of the US counties are primarily rural. 2/3 of US counties primarily rural have no practicing psychiatrists, 41% have no psychologists, and 81% actually have no psychiatric nurse practitioners. So these are worrisome statistics that reinforce that strengthening the workforce pipeline to add more entrants into the workforce is just one component of a workforce development strategy. Providers really need to be well trained and committed to practicing in areas that are needed for service provision. Oops. All right. So although I'm not an advocate for basing supply interactions on supply interpretation simply on provider headcount, we have conducted some provider distribution studies in our center. So this map is showing distribution of psychiatric prescribers, understanding that this is just one segment of the workforce and of care teams. We looked at provider to population ratios for psychiatrists, for psychiatric nurses, physician assistants who are specifically doing work in behavioral health and psychiatry, and psychiatric pharmacists. And no surprise here, psychiatrists are making up the bulk of the workforce at 71% and driving the distribution pattern that we're seeing. The darker blue represents higher density of providers in this case, and we see that clustered in the Northeast region of the country. The lighter colors have low density of providers, and we see significantly smaller concentrations of providers in southern and central states. This general distribution pattern held up when we looked specifically at psychiatric nurses, who were also a bit more concentrated in the Pacific Northwest. For those smaller provider categories of PAs and pharmacists, the distribution pattern was more mixed, with pockets of the country having higher density, especially so in the Midwest states. But again, we're looking at quite small numbers for those providers. We've also been interested in distribution of treatment facilities for both mental health and substance use disorders. Here's an example of the distribution of location data for facilities that participated in SAMHSA's National Survey on Substance Abuse Treatment Services in 2018. So we can see SUD treatment facilities heavily concentrated on the East Coast and in the urban centers throughout the Midwest. Those are represented by these yellow dots. This pattern coincides somewhat with what we saw for distribution of the psychiatry workforce, with a high concentration of facilities in the East Coast and perhaps a greater relative concentration in the Great Lakes area, Midwest area than on the previous slide. Scarce access to facilities as we move west and we move south. So a question here is, what types of providers are providing care here, and how might that workforce composition be varying by the geographic area? I've got one more map for you. So this is the same facility data, but now looking just at those sites providing buprenorphine treatment and pairing it with census data. Those sites are heavily concentrated in the metro areas on the coast again, as shown by the yellow dots here. The shades of green represent population. So the darker the green, the larger the population. And counties with lower populations, predominantly rural counties, are less likely to have geographic access to buprenorphine treatment sites, with many counties having no reported sites really anywhere around them. So, these data are subject to all of the limitations that are inherent in these data sets, but they're providing a consistent picture of the distribution and the access problems and really how incredibly stark they are across the country. Now, these maps, these statistics are pre-COVID. I wanted to frame this information today in a way that suggests that we not only need to develop a behavioral health workforce sufficient in size and in skill and recruit them to the right places to have hope of being even close to on the right track in the next 10 years, but we also need to develop a resilient workforce. COVID-19 has had a significant impact on the workforce in many ways. This information here is closer to the start of the pandemic. The National Council for Behavioral Health surveyed behavioral health organizations in April. And what they found was that over 60% of the responding organizations believed that they could only survive financially for 3 months at most under the COVID-19 conditions at the time. And less than 10% of responding organizations believed that they could survive a year or more under the COVID-19 conditions that were happening in April. Nearly all reported reduced operations that resulted in canceling client appointments or turning away new clients. And nearly half had already or planned to lay off employees. So these are really concerning findings because, of course, we expected an increase in demand for services, not just through the duration of the pandemic, but for years after as well, with the impact of social isolation, financial distress, business and school closures as exacerbating factors for behavioral health concerns. We've seen alcohol consumption increase significantly during the pandemic as well. So we have a state of workforce shortage and maldistribution pre-COVID with behavioral health service needs skyrocketing during COVID. We also have significant strain on the workers themselves who are trying to also survive the pandemic financially, physically, not immune to the challenges that their clients are facing. Many states have adopted initiatives to help flex and surge this workforce, and this included strategies such as expanding provider capacity with students and with retirees, designating more facilities and staff as essential critical infrastructure workers, so community mental health centers, FQHCs, residential psychiatric facilities as an example, recruiting out-of-state providers to help flex and surge the workforce. And then we saw some changes in education requirements for training programs, so virtual or simulated practice experiences and more flexible requirements to expedite initial licensure. We also saw models of service delivery change virtually overnight. Scopes of practice and payment regulations for telehealth were expanded. The CARES Act helped support things like continuity of care for existing behavioral health clients and some changes around provider payments and allowances for serving out-of-state clients. There are now allowances for audio-only care and previously restricted video technology. And telehealth is included as a Medicaid covered benefit by states. So, this is all pretty substantial change to the care model, and one that perhaps behavioral health would have taken a bit longer to embrace if not for the pandemic. But it provided a mechanism for behavioral health organizations to keep their workforce working, to trying to meet service demands, and to help with access to care for some who previously struggled to reach a behavioral health specialist. That being said, we know that some communities, rural and tribal in particular, lack broadband access availabilities. So, certainly infrastructure upgrades are needed in underserved communities to fully realize a promise of telehealth. In terms of enduring behavioral health effects of COVID-19, as was already mentioned, we expect to see short and long-term implications for mental health and substance use disorders. The Kaiser Family Foundation poll shown here was published in April, and suffice to say, percentage has increased over time. We expect both previous and new users of behavioral health services to seek care. But we can look a little bit to previous pandemics to get a sense of what we should expect in terms of demand for behavioral health services post-COVID-19. And generally what we see is psychological stress estimated to last up to at least 3 years post-outbreak. So we're very much in the front end of this and thinking about how to not just sustain workforce capacity now, but how the changes being made during this public health emergency may need to be extended to address behavioral health needs long past the COVID-19 crisis. We also want to be mindful of stress, burnout, and psychological trauma in behavioral health workers. So an already stretched and strained workforce working under very difficult circumstances. So in summary, the behavioral health workforce is broad in scope, many occupations, levels of training, and scopes of practice and authority. So far, research efforts have been primarily focused on core licensed professionals, but we certainly want to be more inclusive than that. We know there are supply challenges with the behavioral health workforce. We really need better data on the full workforce so we can start tackling some of these shortage issues and better advising on some evidence-based practices. The COVID-19 pandemic is exacerbating these issues for behavioral health providers, but the behavioral health workforce is resilient. Providers are facing a ton of challenges and barriers from their own personal stress and burnout, but also needing to learn how to develop a new mode of care delivery virtually overnight. So they're resilient, they're doing it. They need continued support from policymakers to ensure that they are compensated appropriately and provided full practice authority. So I recognize this might feel a little bit like a doom and gloom piece of the presentation, but I want to put in a plug for optimism. This has been a tough year, but this crisis has also prompted innovation in so many ways. If there's ever a time for the behavioral health system, as fragmented as it has been, to pull together, it's probably now, and that's a pretty hopeful thing. So I want to transition in my last few minutes to share some information about workforce development policies and practices. I want to draw some attention to HRSA-funded programs that are trying to prompt recruitment of the behavioral health workforce. So the Behavioral Health Workforce Education and Training Program, or BWET, aims to increase behavioral health workforce supply and really try to get at this issue of maldistribution. So over 10,000 trainees have entered the workforce as of 2018, and really trying to focus folks into underserved areas. Similarly, the Opioid Workforce Expansion Program supports community-based experiential training in the provision of OUD and SUD prevention, treatment, and recovery in these high demand areas. So this is a newer workforce training program that was developed to address workforce factors associated with the opioid epidemic. And as we know, this is yet another example of a behavioral health priority that has been exacerbated during COVID-19. In terms of OUD treatment options, we look a lot at medication-assisted treatment, and including both pharmacotherapy and counseling and behavioral services. I bring it up because in thinking about workforce development, this is an area that our center has spent some time trying to dig into, because although a best practice, MAT remains fairly underutilized, and some of the things we hear from providers have to do with inadequate training. Along with financial constraints of the organization and challenges in leveraging technology. But that workforce development piece is an important one. And as we continue to expand, telemedicine care for OUD, and ease some restrictions related to OUD treatment, keeping that workforce development piece in mind is really important. This is all good news that there has been there have been efforts to help expand treatment, particularly during COVID-19. We still think that we need, more standardized training around addiction. We need to create mechanisms to enable access for MAT despite geographic barriers. And providers are telling us they need more technical assistance guidelines for how to utilize this treatment appropriately. When we surveyed nurse practitioner and physician assistants who were MAT providers, they also gave us this feedback. So adding MAT to graduate program curricula, increasing providers' access to peer support. So they really were interested in having that linkage to peer services when they're providing MAT. And then they also talked about integrating behavioral health in medical settings. So in many cases, providers with waivers to provide MAT were declining to do so because they felt like they didn't have an accessible behavioral health clinician to follow up with the patient. So, that's a real barrier to care. Other federally supported programs I won't spend too much time on. I suspect you're probably familiar with the Graduate Psychology Education Program, another HRSA-funded program that's looking to train psychologists to serve in high need and high demand areas. And there are other loan repayment and scholarship initiatives as well, with probably the most prominent of which is the National Health Service Corps, which was expanded in the past few years to include more emphasis on behavioral health and behavioral health professions. So we have a lot of investment in workforce development programs. I just highlighted a few of the federally sponsored programs. What we don't have as much of is evaluation studies to determine which elements of these programs are most effective in recruiting the workforce. So I wanted to put a very quick plug in for a resource that our center developed working with those BWET grantees who talked to us about what type of information they needed to better equip themselves to evaluate their program. So we do have an evaluation toolkit available on our website for program directors to help structure an evaluation program for their training programs. Training programs certainly offer promise for workforce recruitment. As was mentioned earlier, retention is also a very key issue. And I won't go through the details of the studies related to retention here. You can find them on our website, but I will just note that, our studies did show that there was a perceived limit to opportunities to advance. So many of the themes that Chris mentioned at the beginning about career ladder and feeling unable to advance into leadership positions was a notable theme, and it came out particularly among respondents who were providers of color. We also undertook a pretty ambitious qualitative study last year that was aiming to determine what states are doing to address recruitment and retention of behavioral health providers in rural areas. These are some of the common themes that came out in that study. The full report is available on our website, but there is some information about some promising practices or some innovative ideas that some states have undertaken to try to expand and retain their workforce. We also have a toolkit around these findings. So available on our website, information about funding mechanisms, state regulatory suggestions, details about public-private partnerships that some states have found valuable, and some descriptions and links to some innovative pilot programs. And so I will just close here in saying that, these are a summary of some promising practices in recruitment and retention. I've gone over these to some extent already, but again, they are detailed in some of the reports on our website. In terms of future needs, these are some of the key points that we think could help improve behavioral health worker recruitment and retention. Some have to do with better data collection to inform planning efforts. Some have to do with expanding loan repayment and scholarship offerings. Some have to do with things that impact job satisfaction and retention. So assessing and refining legal scopes of practice. I didn't spend much time on that today. I could do a whole hour just on scope of practice. But in general, we know that providers tend to stay places where they feel like they can practice, where they have full practice authority. From our center perspective, we will continue to focus our research on these key themes to try to address workforce shortage in vulnerable and underserved populations, in thinking about payment factors that impact service delivery, discipline-specific studies that can also contribute to the discussion about how to better integrate care and care teams. So thank you for the time this morning and for your commitment to strengthening the behavioral health workforce, particularly during this time of emergency. Please feel free to connect with me if you'd like to learn more about our studies and the resources that we have available. So thank you.
Thank you very much, Dr. Beck, for providing such a detailed analysis of the numerous challenges that are facing the behavioral health workforce. But we are also appreciative of the fact that you highlighted, you painted a positive outlook in terms of initiatives that are happening at the federal level in order to ensure that we are addressing these issues. We will open up the chat room and invite attendees to ask questions. But one question that was posted earlier that I would like to put up here, let's see in a minute. So one attendee asked, do you have any data that are broken down to show concentration by bilingual and multilingual candidates in the US?
Fantastic question. We don't have those data. I wish we did. I would say, you know, as limited as our overall view of just aggregate numbers of the workforce, when we try to get even more specific into characteristics of the workforce, you know, that information becomes more and more sparse. It's a wonderful question and something that we should strive to capture.
Thank you. We have another question for you. What role would be most helpful for philanthropy to play in diversifying the behavioral health workforce? What programs or promising practices should they focus on funding to complement HRSA programs?
Oh, that's another wonderful question. And I'm not sure that I have a very short, concise answer for you on that. You know, I think partnerships are so critically important among philanthropic organizations, state organizations, local organizations, nonprofit organizations of other types. You know, I think what we're really seeing in health workforce overall is a need to organize the efforts that are happening. So I think behavioral health workforce is on the radar of a lot of folks right now. It was pre-pandemic, it's maybe more so.
I'm at a workshop. Can I call you when I'm done?
But what we tend to not see is a whole lot of just collaboration and aligning the efforts together. So I would say that is probably step one, is whatever jurisdiction or whatever piece of the population you're trying to help serve is just figuring out who the partners are and aligning those efforts at the beginning.
Excellent. Thank you. Just checking to see if there are any other questions here. Shawnee Dowd, thank you for being here. You added a comment in the chat room, but I would like to invite you to share it with the group. Shawnee? Don't forget to unmute.
Yes, sorry. Sorry about that. Thank you for that great presentation, Angela. I was thinking about a comment by Parinda Khatri earlier on the fact that the supply of providers doesn't take into account access to uninsured and underserved populations, because so many providers don't take Medicaid because it's just not fiscally supportive of that work. And I think that's a really critical piece, because it means that even if you have providers, you have the heads in the offices, they're not available to most of the population. They're available to those who can pay out of pocket. And then when you add to that, providers who do work in community-based centers and services who do take Medicaid and other such programs are generally asked to work as fee-for-service staff.
Mm-hmm.
Which also undermines the individual's ability to maintain their own fiscal health. And so people tend to not stay in those jobs very long, and there are always a lot of openings. So I think that there's the issue of bodies in the seats to begin with, which you really did a great walkthrough, Angela. But there's also the issue of what happens when those bodies in the seats are out in the community, who get what kind of attention from what kind of provider. Because that over the last, I've been in this for 40 plus years, more than 40 years. And that right there is a very substantial barrier to people actually getting access, even when there are 3 psychiatrists lined up in the hallway.
Completely agree, and thank you for spending a few minutes to point that out, because it wasn't highlighted sufficiently in the presentation. But you're right, and this is another example of why headcount and FTE can't be the way we look at this problem. It's insufficient. It's necessary information. It's insufficient to drive workforce planning policy, and you just highlighted a wonderful example of that.
And thank Perinda Khatri for.
Yes, thanks Perinda too.
Can I jump in? This is Audrey, just on the second point that Shani was raising. There's so much innovation in payment reform for primary care and value-based payments, even more broadly than primary care, but so little in terms of payment reform for behavioral health, so that even in community health centers in Massachusetts anyway, where there's a prospective global payment for much of the care that is delivered, behavioral health is still paid for on a fee-for-service basis. So there's, we really have to, I think, look at that issue at all as well. It's not just, it is amount of payment, but it's also the form, the structure of the payment that's really disabling, I think.
Thank you very much. There is one more question for you, Dr. Beck. First, the attendee started by thanking you for a great and clear presentation, and he or she especially appreciated the statistics that you shared. And here's the question. Does HRSA offer funding to agency for training of staff, or to offer opportunities in their communities for targeted training and or education in order to attract candidates, especially those who are bilingual?
That's a great question. Chris may have more detailed information on that than I do. My understanding of the workforce training programs that HRSA supports is that they do have some criteria as to how they need to train that workforce. So, some stipulations around types of communities served. Now, whether they specifically recruit for things like, bilingual providers, that I don't know. I'm not sure if that is part of the eligibility criteria for those programs.
Yeah, I don't think anything is that specific with regard to the language.
Yeah.
But again, I really encourage people to go to the HRSA website, look at some phenomenal new programs they have out there, particularly within the BWET program. And I apologize for the echoing.
I do not see any other questions in the chat. And with that, I would like to extend our deepest gratitude again to Dr.
I see one that was recently added. We have a question. Does this research include direct support workers? Many of them are people of color. They work several jobs and shifts and get paid the least.
I would say there is not enough research on that segment of the workforce. So, yeah, the primary bulk of funded research, unfortunately, does not include that group. And that's something that needs to be expanded, because completely agree with that sentiment.
Are there any other questions for Dr. Beck? Thank you again, Dr. Beck, for joining us and for providing such a stimulating presentation, highlighting the scope of the challenges that we are currently facing in the behavioral health workforce. We will now transition to our first panel presentation. It gives me great pleasure to introduce the 3 colleagues who will be speaking today on successful career ladder models in behavioral health organizations. First is Dr. Parinda Khatri, who is the Director of Clinical Services at Cherokee Health Systems in Tennessee. Following Dr. Khatri, we will invite Dr. Maria Battison, who is the Associate Dean for Equity, Inclusion, and Diversity at Heller School of Social Policy and Management at Brandeis University, to present her perspective on the topic. The panel will close with a presentation by Ms. Karen Schack, who is the Senior Program Manager at Commonwealth Corporation in Boston. We ask that during the presentation that you please use the chat to post your questions, as we will have a Q&A session at the end of the panel. All right, without further ado, let's turn it over to Dr. Khatri. I've given you co-host privileges, so you should be able to share your screen.
Okay, can you see my screen now?
Not yet. We can see you, but not yet.
Here we go. Let me see. You would think after months and months of Zoom, we would be doing this like this, and it's always a few steps. Okay, can you see my screen now?
Yes, yes, we can.
Okay, so yes, thank you very much, and thank you for inviting me, and that was a great presentation. Thank you. This is a topic that's really important to us. At our organization, Cherokee Health Systems, we are we're a federally qualified health center, licensed community mental health center, and licensed alcohol and drug treatment facility. And we're in 14 counties in Tennessee, all the way from these are our beautiful Smoky Mountains. We're in Knoxville, Chattanooga, Memphis. It actually takes me as long to drive to Detroit, Michigan, from Knoxville as it does for me to drive to our clinics in Memphis. So that's how it's a long, wide state, but we are mostly in rural areas in the mountains of Tennessee. So this is just a little bit about our organization. So we're really known as and have kind of developed as an integrated behavioral and primary healthcare organization. We have a saying, Cherokee goes where the grass is browner. And recently in our expansion into Memphis and some of these urban sites, we say, well, concrete is also brown grass. So we go that's needed, and training of healthcare providers is an absolute priority for us. It is incredibly selfish because we are desperate for workforce to help us do our work. The need is tremendous. Tennessee did not expand Medicaid. We are 30% uninsured. And then certainly there are all kinds of limitations with Medicaid. So, we needed a workforce, and we were not getting it just by putting out ads. So we, a long time ago, decided to train our own. And that has been one of the best. I think it saved us, absolutely saved us to move to that. So with that, let me talk a little bit about our experience in training. I love to call us we're a learning health center, and that means our commitment to growing healthcare professionals is cross-cutting disciplines. So we've been training healthcare professionals for 40 years. We are an area health education center, also supported by HRSA. Thank you, Chris, and our HRSA colleagues. We have an APA-accredited doctoral internship program, postdoc, school site consortium that we're part of, and then we do train quite a bit of social work and psychology, and I need to add counseling because we've expanded into counseling. And then we've also understood the need to retrain people who have come, who are already licensed, so we do quite a bit of training, and we've worked with William James as well in the past. So this is in our blood. I think health centers, FQHCs are terrific sites for learning, and community health centers. The safety net is my bias, a wonderful way of really learning the skills, competencies, and team-based proficiencies that you need to provide good care. So this is we got a NAC, which is our organization, did highlight us as an exemplar learning system. So when I think a little bit about what's been effective and what's helped us build career ladders and professional development, like, I think has been said before, there is no way we can afford to pay people what they could get paid basically anywhere else. They can go to the VA and make a lot more money, private practice, hospitals, et cetera. So I think we have to be very intentional about growing our own, but also creating an environment where people want to stay. And it's an ongoing challenge, but we do this, I think, in two ways. And one is the active strategies. So the experiential component is important. This goes from bringing people in as AHEC scholars or as trainees or practicum students, which actually it does take a lot of time. You have to supervise the selection, all the didactics, all of that. It's an investment. And then we are very involved in mentorship. So when trainees come on board, they are assigned a mentor. And sometimes their mentor is not even their direct clinical supervisor, but it's somebody else who they can take time to talk with about their future, their interests, that kind of thing. So within that experiential piece and that mentorship piece, we're very intentional. And so about growing our own and recruiting. So within, half a year of training, or as people come in, we will say, we're really interested in you joining us. Or if you already work for us, we're really interested in helping you grow and develop. And I just say, where do you see yourself? What are you passionate about? And how can we help you develop? And we just make that explicit. So that has helped us go into areas that we would have normally not gone into. So a number of our services started not because it was my idea or an idea from the leadership. It's because we had a newer hire who said, I'm very passionate about HIV and I see this need. I think we need more PrEP navigators. I think we need to partner here. And we say, you go for it. You know what? This is now your project. The passive strategies are probably just as powerful, and that is a culture. Setting a culture where people are valued, where mission and commitment to health equity is just inculcated. And that's why we start early. And now, I've been saying we need to partner with HOSA programs. Because we need people to fall in love with this work. We lose enough as it is, right? When people have loans or et cetera. So the culture is important, and we have a learning culture, but a culture where people feel like it's okay to try something and fail. And I will take a leap and say, okay, I'm going to try this, but I'm not going to be fired, or I'm not going to get, raked through the coals if I make a mistake. We all make mistakes. So when you're building a career ladder, you have to learn your lessons, and it's okay. I've made mistakes, and we've got some epic ones that we share with each other. But I think that culture is important. I think role models are important. Behavioral health providers need to see, oh, I can be that. And one of my favorite things is when we have someone, in fact, this happened just a few months ago. We had a front desk person. He's a check-in. He's a receptionist, front desk person, and he is of Latinx. He's Latinx, and we have a wonderful psychologist who is also Latinx, and she was cycling through our clinic, and he basically sent me an email, and he said, I want to be like Dr. Rodriguez. How can I be like her? And this is where the intention is. I was like, you meet with me tomorrow, and let's carve a path to take classes. This is the path, and here are the different things, and here's everything we can do to help you. So what I love is to see, and we've had people who are peer support, community health coordinators. They go and they get their master's in social work, or they get their certifications in counseling. So that role modeling is critical. And then I really am a big fan of multidisciplinary role modeling and teaching. And so one thing we do for our behavioral providers is we have them shadow and work with other professions. So they will shadow primary care providers, clinical pharmacists, nurses, and we have the same for our students in those other fields. I think it makes you better at what you do, and it makes you understand things from a broader perspective. So as you're moving up from a clinician to a director level position, and almost all of our director level positions, in fact, it's fascinating. If you look at our director of research and health equity, our director of school-based therapy, in fact, our chief operations officer was a trainee with us. She started 12 years ago as a trainee, 13 years ago as a trainee with us. They all started as trainees and they built up. And so now others get to see that. The lessons learned, I'm just checking my time. I don't know if there's a way of doing this without resources. If someone can do it without resources, let us know. It is time, and this is where HRSA has been helpful just through the GPE grant. We don't qualify for the BWET grant, but because we're not an academic institution, but the GPE has helped us with psychology. HRSA has given wonderful expansion grants, but it has also been just sheer grit and creativity and, robbing Peter to pay Paul and doing this and doing that and partnerships. But it takes time, it takes money, it takes equipment, materials, it takes a lot of energy. And so it's not like an easy thing. And I think we have to recognize that. The selection is really important as well. So you need good raw materials, you need like good ingredients to make a cake. And so we interview our trainees. We spend a lot of time interviewing, and people cannot believe how much time we spent on selection. But every time we've hired a body just to hire a body or to accept a trainee just to fill a slot, we have paid for it. So you have to get people who have some underlying raw material or data or interest in, particularly for us, our mission is toward the underserved. So if someone comes in and says, it's just not going to fit our culture, they could be great. But if they say, my goal is to go into private practice in this very wealthy neighborhood and I'm just going to have a cash only, we're not a good fit for you. Or if someone says we're a team-based culture, if someone says, I want my door closed, I like to do my thing, and then I close the door, that's really important. That's just not going to fit our culture. So we have talked to a lot of people who have struggled with building leaders or having success career models. And I just say, where did you start? Did you select for that way? So the selection is important. The relationships, I think so much of it is about building relationships with people. So people feel like it's a safe and just culture and they feel comfortable and they're like, listen, I just have to tell you this. And not in kind of a, I want to point out a problem way, but I want to make things better way. So you have to have those relationships and trust. Trust is so important. And anyone who develops within our organization, the first thing we do is, people have to trust you. You have to be safe and people have to trust you. And that goes to observation. When we think about career ladders, I always watch. I watch how other people look at a certain person. People choose their leaders. People choose your leaders. You go, often people are already the change agents and leaders before you give them the title. So we've had several instances where we've given people a title, you're director of, our director of behavioral health training, or you're director of this clinic. And people will say, oh, I thought that was that person's title, because they were already functioning that way. So observe and look at people's strengths, but just know that there are people who rise to certain, our director of pediatric integrative services, is a clinical social worker who has been in peds. She was already, always sending emails about our well child checks need to be, our anticipatory guidance needs to be this way. This is what we need to do for retentive encopresis. This is, et cetera, et cetera. And people kept going to her saying, what should we do about this? What should we do if a family shows up without the child? So when she made that transition, it was just a matter of formalizing what's there. And here's just finally my recommendations: invest, invest, invest. It has been one of the blessings of my life and gifts in my for our organization to invest and give the resources, time, whatever you can, in building a workforce. Just like we heard before, we don't have enough people. I'm ballparking this. I think we could triple the behavioral health workforce and it still not meet the need. Look at the pain and suffering. When you look at the number of people who are dying in our ERs of opiate overdose, people who are dying of suicide, people who are suffering and just the economic cost. And the majority of them are not accessing behavioral health services. There's a manifest demand. That's the demand that's manifest. And then there's kind of this hidden need. So we need to address that. Partnerships also, where health centers we're all about partnerships, but we cannot do it alone. So partnering with academic institutions, partnering with community-based organizations has been really wonderful. And advocacy, we're still fighting. Even right now, we've got students who are providing clinical services, and we're still having to fight with regulatory bodies saying, they're supervised. They actually get 2 clinicians for the price of 1, and they're saying, no, they can't do this. They can't do this. You can't have a student see this patient. And I'm like, this student is thinking more about this patient than anybody we have on our staff. And every note is getting reviewed. We are monitoring everything, but it's such a battle to just little things like that. So we are always advocating. And then this is a long-term commitment. When we started our internship program, I would say it was a solid 5 years or 6 years before we could actually see the fruits of our labor. And so you have to kind of think of it as a long-term investment. I wish it was just a magic fairy wand and, you start training and you start developing and then all of a sudden you have a great workforce. But, I started this program, the internship program 18 years ago. And I'll tell you, it was the first 5 or 6 years, I was like, okay, just keep doing it. One day it's going to pay off. It's going to pay off. So that's it on my end. So I'm going to stop share and I will let you transition to the next panelist. Thank you.
Thank you very much, Dr. Kadri. A few questions have been posted on the chat, but we will leave all of them toward the end. And now we will invite Dr. Maria Madison to share her experience regarding how to build successful career ladders in behavioral health organizations. Dr. Madison?
Thank you so much. Thank you to you, Dr. St. Louis, as well as Mark Abelard and William James. We all have heard so much data, and it is often disturbing data. Just a little example of what I'm always perking in the back of my mind is from the American Academy of Child and Adolescent Psychiatry. That the majority of the country faces a severe shortage of practicing child and adolescent psychiatrists, with fewer than 17 providers available per 100,000 children. And we see the impact of these types of data in the programs we've been able to work on with Mark, for example, Abelard, with you, William James, through a couple of our programs, one of which is our Hope Institute, which works with criminal justice involved youth in trying to provide wraparound services for Boston adolescents who are both in and out of high school, but also are involved in the criminal justice system. And so in our program that was created by a wonderful colleague, Janelle Ridley out of the Boston Mayor's office, we are not only trying to provide them with role models and the wraparound services for mental health and race equity, but also academic opportunities so that they can make their way into the pipeline of reaching into higher ed, so that hopefully they too will become eligible, available to put into the workforce pipeline, to become counselors, to become mentors and advocates themselves. We try to do the same thing as part of our CHNA 17 grant, which is the Community Health Network area grant out of the Mass Department of Public Health, where we work in mental health and race equity, and particularly, again, with our work with you all and Mark in particular, with an undocumented community. The work that we see there, the challenges that we see there, and particularly with bringing in individuals with lived experience and the expertise in the mental health field, is that we're able to match cultural competency, cultural humility in the dialogue between providers and clients in trying to address the unmet need of this undocumented community. So what I'm describing basically is that we need to build a community workforce, and that to do so is about pathways, pipelines, and building relationships. And that those relationships really are about reciprocal, respecting lived experiences as a skill. When we work in these communities, whether it's criminal justice involved youth or whether it's undocumented populations, we are calling upon as well community members to be a part of building what the previous speaker beautifully described as trust. We want to build mutual trust. And we also then want to make sure that whatever model we come up with can help emphasize the need for equitable pay, for a career ladder to leadership roles, and that sometimes those pathways have to be parallel tracks that are creative, especially if some of these individuals are undocumented but have the skills and have the lived experiences that can make a difference in the mental health of a community. And so sometimes that's through scholars, visiting scholars, or visiting fellows, or hiring, just viewing hiring as a reciprocal investment. It's an investment not just for the organization, but also for the individuals who are investing their social, emotional selves in the process. So we hear the clarion call, and we see that we need to hire with diversity in mind, and that it's needed now more than ever, and that it actually represents interdisciplinary, multilingual, multicultural demands on every organization. And so what does that mean? It means we need to think beyond just focusing on the classic categories of hiring for diversity. Sometimes people think hiring for diversity means they brought in a Black person. It means going beyond BIPOC, Black, Indigenous, persons of color. It means also, as all the previous speakers beautifully described, focusing on bringing into the workforce the underserved, those with lived experiences, those who may be undocumented, those with linguistic skills. We're living in a time where the population is majority minority already in Boston and in the rest of the country by 2044. What does that mean for our ability to nurture a pipeline to make sure that those who are most impacted by structural racism, including the pathways that are exacerbated by COVID-19, become a part of the workforce we need to make the change in the overall health of a community, physical and mental health of the community. That includes equally recognizing the impact of this on the various populations, including now the magnified impact of COVID on the Asian population, and the anti-Asian sentiments and the impact on mental health of LGBTQIA and veterans. And so these same populations that we want to nurture and bring into the workforce are also those who are disproportionately saddled with debt, decreasingly able to make it to higher ed, and if they do, more likely to have debt. So what kind of employment or pathway to the career ladder can we provide that might even provide debt assistance or a debt assistance model in hiring and continuing education and shadowing? What is the support we're going to provide them? So I just have 4 or 5 tips for things we're aiming to do. I cannot say that success is the norm. Success is not the norm. I hope I'll remember at the end to just say what I've seen works, but a few tips that make the difference is when we think about what to do in the whole process of creating a pipeline and pathway to a culture of diversity in our workforce. Training is at the center of that. And at the center of that training is cultural humility. And I'm not referring to training of just the search committee. I'm talking about training of the institution before you even think about hiring and doing a search process. And that training is about cultural humility. It's about multiculturalism for the search committee and the entire community of employees and everyone else in your environment, to promote increased diverse hires, yes, but also to transform your institution into one that is welcoming and respectful. And so then, you know, that training process is a cornerstone for the hiring manager, to be sure, and that the next part of that process then is to make sure that there's an objective job description, one that promotes the recognition of the value of lived experience, as well as additional skills that come through more traditional pathways. But those traditional pathways have been more readily available to documented residents, for example, more available to those with means or wealth or income. And so there has to be a broader sense. If there is the true intentionality to create these multidisciplinary, multicultural workplaces that meet the needs of our communities, we have to recognize how to train to match those characteristics. So you can, you know, use various tools to check your job description for gender neutral, diversity and inclusion supportive language. There are tools online. I'm not going to list them. I won't do a PSA for them, but you can find those tools online. And then you can also consider an online, well, I won't list the tools, but you can schedule those trainings with your committees while also enlisting all of the individuals in your institution to participate in trainings. One thing I will list that is helpful in that entire backdrop before you even post or think about posting a job description is something I've seen that is available online. It is free and it's something to think about. And it's called the 21-day challenge. I don't know if any of you have engaged in that, but it's one of the things we're starting to test out. And it was designed by Moore et al. So if you look up the 21-day challenge by Moore et al., what it does is it creates a framework by which your entire community, your workplace community or any community for that matter, can engage in a 21-day lesson plan to understand, for example, in this case, it's Black forward. And so day one, for example, is Nicole Hannah-Jones on America wasn't a democracy until Black America made it one. And so each day there is a different kind of pedagogy in there that you can challenge yourself, engaging in music, art, literature, different aspects. And so consider adopting one of those. The American Bar Association has adopted it, for example. And imagine if your organization adopted it and then at the end or along the way engaged in a dialogue, an online conversation on how you're engaging with that information. This not only transforms the way you might approach the search process as a committee, but also creating a welcoming environment for once you recruit for diversity. So, so that's a few of the training concepts. And then, you know, undertaking that focused and search also means targeting various resources and places to look for diversity, including, of course, HBCUs, as well as Hispanic serving institutions, And according to National Association for College and Employers, NACE, the two most common sources for diversity recruiting among employers have been HBCUs and HSIs. But consider that holistic, sustaining approach. This isn't just about searching a target and building, but also about building strategic partnerships. And so you're not just looking to hire someone, you're looking to build partnerships, which has come up in the previous presentations as well. So you want to do that organically even before the search, building a partnership with schools that recruit students from a variety of backgrounds, and professional organizations, including philanthropic, which was described earlier, organizations around predominantly, underserved or those various identities that we've spoken of. And then you want to attend and or host virtual career fairs for those populations, those diverse populations and student groups, to help with the pipeline of bringing people in, even if they haven't graduated yet, bringing them into these post secondary education pathways, parallel tracks for scholarships, and visiting partnerships so that they could shadow someone who's in your organization, such that when they do graduate, you've primed them to be a part of your organization. There are a variety of places online, again, for this. I will mention a few, not to market them, but just to give an example of what they're like. But Career Echo Bender Virtual Career Fair, it's a career fair for people with disabilities, and they have over 1,000 registrants. Are getting hired through Brazen Connect, again, disabilities focused or veteran recruiting. Promote the job announcement through your various connections. We all know that many of us get our jobs through our networks. And so work those networks, build out your networks. If your 6 degrees of separation are homogenous, that is, represent your demographic, then build out your network. And so post through various types of social media, get to know the types of social media that various populations and identities use, engage with the philanthropic opportunities that work with equity, inclusion, and diversity, engage with staff and student working groups, organize specific and short-term events for underrepresented populations, and then hold the institutional accountable through tracking and reporting. And by that, it's not just tracking and reporting when you're posting a job description again, it's about who's in your workforce now. What training have they gone through? What kind of cross-cultural and cultural humility training have your current workforce experienced? What kind of conversations have you had as an organization? And then keep track of who you're bringing in or who you're nurturing to bring in from high school on through undergrad and graduate professional degrees. And then again, prioritize and target relevant sites that are available online, whether it's Latinx, African American, Asian American, Native, women's organization, LGBTQIA, disability, military, veterans, and then organize your interview process to reduce bias in that process, beginning with self-reflection and self-awareness through things like the 21-day challenge, and then role play through that process. And then look at adding DEI questions and situational analysis questions around whether individuals in both your organization as well as the candidate are able to have conversations that are both open to diversity and respectful of difference, but also on how to respond to bias and microaggressions or microassaults or microinvalidation in the process. And skills and experience, lived experience matter. So how will you consider that? How will you create a respectful environment that recognizes that lived experience is as invaluable in this field as both the more formal approach? Often I hear code terms like, that was a wonderful candidate, but I think it's going to be a steep learning curve for her. Where does that come from? Because they possibly went to a school that someone wasn't familiar with, or because their lived experience comes from a rich background of knowing their community, and that is different from a formal education that or a school that someone recognizes on a CV. Have a deep conversation about what lived experience means and how it can be a rich contribution to your workforce. And then consider things about adaptability, ambition, and relationship building, decision-making, conflict resolution, and then agree on how you're going to create a scale to include or be more inclusive in your process. So I'll stop there, but those are just a few thoughts on what we see and what we're aiming for. I can't define success other than intentionality. And for me, at least, intentionality means that the places where I've seen diversity work are where the environment is intentional about respecting lived experience in the broad definition of diversity, and then assures equity when you nurture and bring people into that environment, and assures inclusion in their conversations and in mutual respect in that environment. And so that intentionality means that you're not just hiring a search committee, a search company, for example, and say, you guys go out and do it. You're intentionally finding one that has a track record of having provided an array of candidates to consider. And in that process, I know sometimes people talk about the Rooney Rule, and that the more diverse your base is, and the more likely it is at each subsequent stage, you're going to have diversity all the way up through the top. But bias gets in the way of that. So even the Rooney Rule is not a surefire way of doing this. What works is intentionality. If you don't see a diverse slew or slate of candidates at each narrowing step, you need to keep opening up your search and bringing in that possibility. So I will stop there and thank you.
Thank you very much, Dr. Madison, for your thoughtful and powerful remarks. You have certainly generated a lot of excitement in the chat room, and thank you to colleagues who have posted the links to 21-Day Anti-Racism Challenge website for others to certainly access those wonderful resources. And we will be requesting some of the resources for the links to the sites that you mentioned from Dr. Madison, and we'll post them on the microsite. Now I would like to invite Ms. Karen Shack to step forward and share her remarks with us. Karen, you have the floor.
Great. Thank you so much for inviting me to present today. And I hope, can you now see my screen?
Yes, you are.
Okay, great. Okay, so I really appreciated coming at the end of this panel, because I think that my presentation really builds on what both presenters have already shared. In particular, Corinda Kotri talking about grow your own. What I wanted to do today was to really kind of dig deep into how to create a successful grow your own model. And first, let me tell you just a couple things about Commonwealth Corporation, which is where I work. Commonwealth Corporation is a quasi-public workforce development organization working in Massachusetts. We partner very closely with state government, in particular with the Executive Office of Labor and Workforce Development, to help administer public funds that are used to address the mismatch between the skills of our current workforce and qualifications that employers now demand. We do this work by investing in partnerships, and we heard a lot about how critical partnerships were. We do this work by investing in partnerships with industry, education, and workforce organizations. And these partnerships help prepare unemployed workers for jobs and current workers to be upskilled to improve retention and upgrades and lead to wage gains. A lot of the projects that we fund also prepare underserved youth for post-secondary education and careers. So the workforce challenges that behavioral health care employers face, we're all familiar with. They've been in place for many years. They're challenges that are faced by other parts of the healthcare service delivery system as well. We know there's a shortage. There's certainly a lack of familiarity with behavioral health jobs, which means that a lot of times people aren't choosing to go into behavioral health organizations. We know that there are limited funds for reimbursements that impact an organization's ability to offer competitive wages. And for many entry to mid-level positions, there's a lot of competition from other industries, retail, hospitality, and other industries that offer equal or higher wages for jobs that are sometimes less physically and emotionally challenging. Occupations with higher wages also often require specialized education, training, or certification and licensure, and that's a barrier. In Massachusetts and certainly in other parts of the country, we know that behavioral health education programs have not always been available in every region of the state. To access education, workers also need funding, which is limited, and time to complete classes and access to technology and wireless access, and often these are limited. Literacy and academic readiness is also a barrier to growth. So these are a lot of the challenges, and we're very familiar with the challenges. What are some of the solutions? I want to talk today about one solution in particular. I have up on the screen lots of solutions with which others so far today have kind of talked a lot about, loan repayment and clinical internships and things like that. These are some of the more common solution strategies. All of them require planning and a long-term approach, and all of them require strong partnerships. So though I'm not going to go into detail about each one of these, today I really want to talk about how one of these options, a build your own strategy, which was referenced earlier, is a really wonderful way to fill ongoing demand. And if it's well designed, it can be a very, very effective model to recruit and retain your staff. So what is a grow your own model? It's a structured and strategic way to fill open positions and retain workers through identifying, training, and promoting your incumbent work staff. Generally, steps include first, selecting the right internal candidates, and we heard reference to how critical that is to pick the right staff. To help them prepare for their new job through skill attainment and support. And then ultimately you're promoting them into new jobs, leading to a promotion or a wage gain. Why is this strategy so critical? Why is it so effective? Well, it shows commitment to your own workforce. It's a great way to support those who've already shown loyalty to you and your organization. 3, you really already know strengths and challenges of the workers you're targeting for these advancement opportunities. Then your candidates know your work culture. And if they know the work culture and they stay in it, they're more likely to retain even with advanced training. Candidates who you select for advancement often have a knowledge of the target job and the job environment. Then the education and training opportunity itself can be used as an incentive to keep people longer within your organization. How do you create an effective and successful grow your own model? What I have listed up here are the steps that we think are most critical. These are the components that you need to know and be aware of if you want to create and manage this strategy. I'm going to walk through each of these components and share my experience on how to design the most effective model. The first 2 things are really identifying your target position. And obviously, you're going to identify a position where you have big demand and one where you're having difficulty meeting that demand with external candidates. Next, you want to identify your target internal candidates, and this was referenced earlier. You might target one group of workers or a number of group of workers who are ripe for career growth. In any case, based on the required skills and experience needed for your target job, you're going to need to be thoughtful as to who within your organization might have the potential and the interest to be trained. There may be a group of workers who are in entry-level positions, and this is, a very good way to address increasing diversity, because we know that entry-level jobs are often filled more statistically with a more diverse workforce. And so if that's your target audience for advancement, then you're going to provide opportunity for more diverse workforce to get trained and to be advanced. But identifying your target internal candidates is very, very important. Based on the job demand and the occupation you've selected to move staff into, you're going to need to select a training or education provider that can help you train your workers for this new job. And partnering with education providers is certainly something that we've already heard reference to. Selecting an education partner is critical based on the academic program or the training program. You might have one or more choice depending on your region. Meeting with more than one school or training program is very, very important. You're basically selecting a vendor or training provider or partner, and so you need to consider the options carefully. Based on the occupation, you need to consider either credit-based courses or non-credit-based options. If you're pursuing credit-based options, you're going to need to discuss the college admissions process and the steps and the academic requirements for education and training for the target occupation. You want to certainly talk with the school about whether they offer credit for prior learning as an option. This can help your frontline workers advance more quickly through an academic program if their previous work experience can be used to provide academic credit. You want to talk about whether the program that you're looking at is a rolling entry program or whether you're going to be selecting a cohort of participants who begin and end at the same time. Do your due diligence in determining the school or training program's readiness or ability to be flexible to accommodate a working student. Clarify what supports the school is going to offer that will align with the supports that you are going to need to offer yourself. And obviously you're going to talk about cost per student for each course or each program. Often costs are negotiable depending on how many people you're going to train. And you also want to talk with the school about what happens if a student is not successful. If a student needs to take a leave or has academic challenges, are there opportunities to enroll at a later date? Or will you get a refund if somebody has to drop the course? If the program is a credentialed program and the results will be a degree, students you refer might also need to be assessed and accepted into an academic degree program. Just remember that this adds another layer and perhaps more time to the selection process, and it can also be a barrier for some students. So when you are running the program and the course, one of the most critical things is, knowing who your primary contact is going to be at the school, and know that that person is going to be accessible for you when you need to get response to questions and more information. You also need to know whether they have the authority to make adjustments if necessary in the program or in the process, if that's what you need in order to help make the project successful. Next, you need to look at your participants and know your participants. And this was also referenced earlier. The decisions you make with your education provider are going to have an impact on how you select participants for advancement. Knowing what you need to know about your participants is really critical to success. You and the school are going to discuss the requirements for success in a particular education or training program. But do you know whether the target participants, your current workers, are academically ready for this program? I would say, please don't assume that they are, because we know that a lot of people can be very successful in their current jobs, but not be academically prepared for success at school. So knowing your target employees, you and the school are going to need to be able to assess their current writing skills and math skills, their English learning, English language readiness, their grade level, depending on what program you're pursuing. If your employees are not academically prepared, can you build in a college prep course program prior to the occupational program that you're going to refer them to? And do you have the time and the funds to do this? Because that adds a whole extra layer of time and also requires extra dollars. And obviously, because so many of the behavioral health jobs require certification or licensure, you want to clarify what the licensure requirements are and how those are going to be addressed by the program and how the expenses for pursuing those certifications or licensure will be covered. In order to select the right workers to fill the target position, you need to know about your workers' capacity. We've already discussed academic preparedness, but you also need to confirm level of interest in the new job. How do you know whether your workers are interested in a particular opportunity for advancement? Do they know what they need to know about the new position that you're targeting? Sometimes workers might not have a full understanding of the responsibilities of their next step job. How are you going to assess their interest or readiness for this next step? Do you need to create job shadow opportunities or tours, mentoring with colleagues to make sure that frontline workers know what the job is? Even if they have some exposure to workers in that next step job, how can you make sure they really understand the scope of the job? So that's a very important component, and we're not just assuming people want to advance into a particular opportunity. And I loved that earlier that Corinda was talking about career coaching and counseling and offering that individualized option. And I think that's a really good piece to add here. But in addition to knowing what your participants' academic readiness is, you also have to talk about their schedule and their home and work commitments. Because if they're going to be going into school, in addition to working full-time, you have to know whether they have the ability to flex their schedule to be able to do their schoolwork as well as work full-time. You have to know whether they have the time management skills to add schoolwork to a full-time work and full-time family life. And if not, you have to decide, are you willing and able to allow staff paid work time to use for school or schoolwork? This obviously adds an extra cost for the organization. But it is one of the decisions that you're going to need to make before you open up access to career advancement opportunities through the Grow Your Own strategy. So one of the first decisions you're going to need to make when you move into this kind of model is who's an eligible candidate to be selected for this opportunity. So you need to design a very clear process to screen, assess, and select participants. And it's critical to making sure it's transparent to everybody who's involved. You're going to work with your college and training provider to come up with a process to assess readiness. And you'll also need to decide, is this going to be a competitive process? How many candidates will you need to screen in order to select a cohort? Will you be selecting participants on a rolling basis or doing a cohort approach? And is everybody who successfully completes the program guaranteed a new job in the target position? If so, does the manager of that department or area participate in selecting participants? And if so, how does this happen? Will you use supervisor recommendations? Will you require a certain amount of time on the job in order to be eligible for this advancement opportunity? For example, some models say that you have to be in your job for at least 6 months in order to be able to be get access to training for advancement. Will you ask for a commitment in the new job? This can often be used as a retention strategy for you. Just by virtue of people being in an education program and it's being supported by the employer, often this is a retention strategy and keeps people working while they're in school. And then you also need to know and have to decide ahead of time what happens to those candidates who stand up and are interested in advancing, but they're not selected. So Perinda and others mentioned how critical coaching and support were for people when they're in advancement programs. Throughout the selection process and during the education and training, participants are going to benefit from the career and academic coaching that they'll get through the school or the training program. And certainly colleges or training programs add a certain level of support. Often it's connected to the tuition costs. Sometimes you have to pay extra for the extra supports, but offering career coaching and academic support from within your employer site can make the program even stronger. And the types of supports most critical are when people are in academic training, you need to help participants deal with work-life balance issues and time management. You have to help them address academic issues or get guidance to access the proper resources at the colleges to get this level of support. You have to help your staff find and connect with each other for peer support. You also have to, if you're offering coaching from within your own site, you have to decide who's going to be that coach. Will it be an incumbent supervisor, a human resource staff person, or are you going to hire a new staff person who will have the coaching role? And if it's an existing staff person, do they have the time in their schedule for these additional tasks? Do they have the necessary coaching skills? And do you, as an employer, actually have the funds to support this extra service? So I know that was a lot of detail about putting a new grow your own strategy in place. Just to close out some of the things that you want to think about in order to make sure that you can make the case that there's value and you understand the return on investment for these kinds of models. You have to understand what your staff costs are up front. It's going to include program oversight, administration, and coaching expenses, as well as education and training and tuition expenses, and other participant support costs as well. Remember that you need to think through what data you're going to want to track and who's going to track it. You need to talk with the schools about what kind of participant level progress, academic progress information the school is going to be willing to share with you so that you can make sure that you're supporting your participants and your employees who are in these programs appropriately. And you need to, track your success, how many people actually advance as a result of these programs, and what your cost savings are in recruitment and retention, so that you can actually make the business case that this is an effective model, because it's not inexpensive to grow your own strategies. And I think most critically, you need to leave time to step back periodically and assess and redesign the model to remember that you may have to make changes and adjustments in the model as you go along. And certainly always remember to highlight and communicate about employee success, because this is, can be an extremely effective way to increase diversity in your organization, but also to support career growth and fill positions. But you have to communicate about it within the organization. So I want to thank you very much for letting me participate. I'm happy, I know we're over time, but happy to answer any questions.
Thank you to Dr. Khatri, Dr. Madison, and Ms. Shack for providing a set of concrete strategies and approaches that they've utilized at their agencies in order to build successful career ladder models. And through their remarks, we heard them highlight the importance of investing time and resources into building successful career ladder models, the importance of strengthening partnerships among different organizations, because as Dr. Khatri highlighted, this work is hard and it is not the type of work that one agency can do alone. We also heard how advocacy is certainly an important key in building sustainable partnerships and making a long-term commitment to diversifying the behavioral health field. At the core of all these strategies certainly lies the importance of being intentional in changing organizational cultures to ensure that diversity and multiculturalism reflected across systems within the organizations that are built and designed to ensure that career ladder models can be successfully implemented. I know we are a little bit over time, but certainly want to allow a few minutes for questions that have been posted in the chart for the panelists. The first question goes to both Dr. Khatri and Dr. Shack. The question asks, when your agencies grew their own and they trained the staff. How long did it take you to get the staff ready for employment and or for growth?
Dr. Shack, do you want to go first, or should I?
Oh, well, thank you for making me a doctor. I'm not, but thank you.
Oh, okay, well.
Well, I think it depends on the occupation, right? I mean, a lot of the models that Commonwealth Corporation has helped to support are taking frontline healthcare workers in entry-level positions and helping them advance into mid-level jobs. And that often requires associate, kind of either certificate or associate degree programs. So if the question is around the timing, I mean, when you're working full-time and advancing into an associate level program, it can take a couple of years, if not longer. So it is definitely a long-term strategy.
Yeah, and I think I agree, it varies. I would say, you know, for some of the programs, it is, you know, when you have a formalized program, it's that part is very structured. But I see this as an ongoing, you know, we're always developing and investing. So even if someone's been licensed 5 years, 6 years, whatever, you're always developing that. We have done a lot of going our own with our peer support. So we have peer navigators, certified peer recovery coaches, peer wellness coaches. And so there is, you know, there may be some state requirement for their training, but there's so much on the job training that happens. And so I think one thing that we have moved to is kind of a level system. So like level 1, level 2, level 3, because someone who's been a peer wellness coach for 1 year is functioning very different. I mean, we have someone who's been a peer wellness coach for, my goodness, 7 years. And so she really is at a senior level. The way we're going to invest in her and is going to be different than someone who's just 1 year, you know, in that role. So yeah, I think it varies, and people are different. But I would say it's ongoing, and then how much someone needs will develop over time, and what they need will develop over time.
So let me quickly, if I can, comment, Dr. St. Louis. I think there's a challenge for academic institutions to rethink what we think it makes a strong student as well. And many of us grew up with GRE exams and folks looking at scores near 800, indicating that these were the top talented people to bring in into our field, and underestimating the importance of variables like compassion and the capacity to engage another person, underestimating variables like lived experience that provides an opportunity for people to, from the very beginning, build a relationship with somebody that keeps them engaged in the work that we do. And it's one of the speakers, it may have been Dr. Madison, talked about, you know, is this person have a steep learning curve to be able to get it? I mean, we have a lot of need in the academies to rethink what is it that we're doing as we're training the workforce. And we need to value different strengths that folks have. People need to be intelligent enough to read our papers, to learn from us as we sit, but the academies really need to do some significant rethinking about what makes a good student, what makes a good professional, and what should be our work.
Thank you very much, Dr. Covino, for your comments. Looking at the chat, I see a lot of comments, but no specific questions for our panelists. I just want to be sure that we have addressed any questions that our attendees may have. Are there any other remaining questions? Okay, good. So we are at the halfway point. We are going to take a short break. We ask that you Please return promptly by 11:20 so that we can segue into the next session of today's forum. Thank you. Please take a break, get up, stretch, get some water, coffee, or tea, and then rejoin us at 11:20. See you shortly. Thank you. Get the recording back. Welcome back, everyone. I hope you had a chance to get up and stretch. In terms of the next item on the agenda, we are delighted to welcome the Behavioral Health Service Core group, which will be led by our own Mr. Mark Abelard, who is the director of the Service Core. Mark will provide an overview very briefly, followed by a presentation by Dr. Jenny D'Olympia, and then we will have an opportunity to hear from 3 of the students who are part of the first cohort of Behavioral Health Service Core at WJC. Mark, you have the floor.
Thank you, Dr. St. Louis. Many of the best practices that Karen identified in her presentation prior to us going on break are key components of the Behavioral Health Service Corps. It's been an absolute delight to work with with our partnering agencies, but more so working with the young people who have applied to our program. The Behavioral Health Service Corps is the paid service learning opportunity for recent college graduates that provides a competitive salary to entry-level positions at leading behavioral health organizations in our state. As part of the program, the scholars earn 9 free credits towards the master's degree. Scholars are also assigned a graduate student mentor to help them get acclimated to our learning community at WJC and to provide peer support. Our partnering organizations provide the scholars with 4 hours of release time on each Friday afternoon to participate in their academic courses here at WJC. You will hear from 3 of our scholars, as Dr. St. Louis mentioned, about their experience in the program shortly. But first, my colleague, Dr. Jenny D'Olympia, will speak to you about the scholars' academics, their professional development, and their clinical training within the program. Dr. D'Olympia.
Thank you. Thank you very much. So we are very excited to support our first scholars for the Behavioral Health Service Corps. We're very lucky to have had so many qualified and dedicated individuals apply to our program. I feel really fortunate to have had this opportunity to be included in the development of this really exciting program and with this really wonderful group. We started with a robust orientation for our students. We delivered 22 sessions with 19 of our faculty and staff presenters. We did do this over Zoom. And while the virtual world was somewhat of a limiting factor, our scholars still rated their feeling of connectedness to their facilitators as one of their highest ratings during a post-orientation survey. Our training program and orientation programs have been built with sustainability and mental health in mind, because we want to ensure the highest likelihood of success for our scholars. In the orientation program, we focused on bolstering resilience in our scholars. We taught them how to use supervision, self-advocacy, self-compassion, personal safety, and basic self-care. In addition, we gave them a fire hose of introductory exposure to diversity, equity, and inclusion, discussed interdisciplinary teams, facilitation skills, the most common psychiatric diagnoses, just to name a few of the topics that we covered. We also talked about child advocacy, parenting styles, social and emotional learning, and gave them a few brief interventions to use as tools as we ushered them into the field. One of the students said, "I'm grateful to have had such a dedicated group of people working together on this, and also grateful to all the faculty members and staff who contributed their time and effort to the success of this first orientation for what I hope will become a flagship program." We continue to develop our scholars by providing weekly support in the form of individual and group mentorship in order to help them navigate their work in the mental health field. This has helped us see some of their personal strengths and growing edges, as well as those in the field. It's also helped us contribute to a continuous cycle of growth. We're also offering our scholars 6 to 9 credit hours at the master's level in group therapy, diversity, and theories of counseling. These classes meet in a combination of asynchronous and synchronous learning during the academic semesters. Our students who need additional supports with academic writing and planning are afforded access to our college academic resource center, where they're given additional tutoring and structure to help them successfully access the curriculum. Again, I'm really excited to be a part of this area of development. Our faculty and staff are working very hard and doing a wonderful job of supporting and building these structures for bringing our new scholars into the field through the Behavioral Health Service Corps. And they're also working hard to support them through mentorship, training, and education. So I'd like to give it back to Mr. Abelard, and he'll be introducing our scholars.
Thanks, Jenny. I think it's worth noting that these scholars did a Herculean job in applying to the program. We launched the program right in the midst of a COVID environment. And our original intention was to have the recruitment process be on campus, but this was done fully online, as well as recruiting our agency partners that happened online in COVID. And these folks, these young people, we're incredibly proud of them. With me today, I would like to introduce Ms. Eva McDermott, Ms. Fatima Abdu, and Ms. Evelyn Monk. Eva, if you wouldn't mind starting us off.
Hello, my name is Eva McDermott. Thank you, Dr. Abelard, for the introduction. I'm a recent graduate at the University of Massachusetts at Amherst, and I studied psychology with a concentration in neuroscience. My reason for majoring in psychology in the first place was the fact that I have close family members that have been affected by mental health disorders. So I knew that I was interested in a field where I could learn more about mental health, behavioral health, and caring for others. Additionally, a silly fun fact about myself that I told Dr. Nelda LeBoy of William James when I interviewed for the BHSC program is that my favorite color is orange, as you can see from my room, and it describes my friendliness and passion for working with others. So this has really been the perfect opportunity for me. I came across the William James Behavioral Health Service Corps program through my senior year career class. And especially during the pandemic, it just happened to be perfect timing because I was looking for a way to learn more about my options post-grad and learn more about the academic steps that I would need to take to further my career in this field. It's been a really great first step, truly, because it's given me a time to get my feet wet, so to speak, and explore my interests in the field. So for the academic portion of this program, as Dr. Abelard mentioned, and Dr. Youngbia, that our first class was difference, diversity, and inclusion. And that was probably the best introduction that we could have gotten to this school and to the field itself, because it really opened my eyes to how broad behavioral health is and its potential to reach a vast array of people with the right training and the right education received by those who want to go into the field. For the working portion of the BHSC program, I was paired with the North Suffolk Mental Health Association, and I work for the Washington Ave Adult Community Clinical Services team in Chelsea as a community support specialist. And it's been a really great fit for me. As a community support specialist, I maintain weekly engagement with persons on my caseload. And the main goal of my team's services is to assist persons living with mental health disorders and mental health illnesses to lead fulfilling and stable lives while also managing their health. So this means that some of my responsibilities include connecting persons served to resources in their community, help teach them daily living skills, provide them support, and also help them find jobs, other things like that. Services that really you might not think of at first outside the managing the mental health part, but these are all important things to helping people lead independent lives. I really enjoy getting to work one-on-one with these people and work very patiently to build rapport with them. Additionally, the team that I've been placed on has been really great. I work on a very diverse team, and I think that that helps bring a lot of perspectives into our workspace. And it really helps me learn from their experience what I can do better in my position. I think that diversity is a very necessary component of the behavioral health field. And it's really great that I can trust my coworkers so well to be very honest with me. And I can bring questions, comments, and concerns that I have about working in this field and on this team. My long-term professional goals include working with youth populations, either as a social worker or a mental health counselor. Working on my team, I'm very happy to work with the adults in my caseload. However, I think it's made me realize that I actually do want to stick with working with younger populations. The BHSC program has only fueled my desire to continue working one-on-one with people and on a very hands-on setting. But some of the skills that I hope to gain in this field and through my classes as the program continues is to talk a little bit more about burnout and self-care. This topic is one that I have discussed at length with our Behavioral Health Service Corps supervisor, Ms. Melissa Cohen. Ms. Melissa Cohen. And also with my clinical supervisors at my partner program. I think I've learned that this is a very necessary and important component as well of the behavioral health service field, because you can't help but care so much about the people that you work with. And it can be very tiring. I end my day thinking, wow, what more can I do and how best can I support the people on my caseload? And it can take a emotional and mental toll. However, I think recommendations that I would have for new students such as myself jumping into this field and potentially this program is to just go forth and start. There's so much that you can learn along the way. I've been very, very fortunate in my experiences to feel very safe and comfortable, but also ready to push my boundaries a bit. And so as long as you stay dedicated and keep in mind the idea of best supporting the people you work with, and that's the best thing that you can do. Thank you for your time.
Well, thank you for that, Eva. Nicely done, nicely done. Fatima, would you mind going next?
Yes, no problem. Or no, I would not mind. Good morning, everyone. I feel like I can still say that. It's only 11:30. I hope everyone's doing well. I'm sending a lot of support. I first just wanted to thank everyone for partaking in this forum and express some gratitude for being able to be part of it as well. I would say it's quite refreshing and reaffirming to be able to witness the continual and collective efforts of such empowering and knowledgeable individuals working to aid in diversifying the behavioral health field. I would say, especially within this year, 2020 has not been easy, to say the least. COVID-19 ravaging the entire world. The Minneapolis riots, death of George Floyd, and many other insurrection, forest fires, the port in Lebanon, and just the unpredictability of what's to come. I think lots of unrest all around in 2020, which has truly brought to light the challenges we're collectively facing, all while highlighting the significant inequities when it comes to receiving adequate mental health support. I think the lack of accessibility, especially within certain demographics, is mainly underserved in minority majority communities, is one of the main reasons why I chose to apply for the BHSC program. I went to UMass Boston for undergrad with a major in criminology, and I hopped around majors for a bit, but I always knew that my passions aligned with inclusive behavioral mental health advocacy. that was accessible and all-encompassing, fitting for whatever population being served. Say diversification is one of the most important things that can be done for the field of behavioral health and all fields for that matter. But yet, despite the increasing attention to issues surrounding diversity in research, science tends to be relatively homogeneous. So I'd like to be the up and coming sort of group population comes in. So and diversity is extremely beneficial, especially for underserved populations who would rather work with someone they feel better able to relate to them, for example. And this in turn yields success with the client and therapist, as well as comfort for both and progressive change. I would say it's critical in building a more comprehensive approach and a key factor in producing work that actually mirrors the needs of the underrepresented populations. I'm currently at the Walker School. I am a direct care counselor and work predominantly with ages through 13 facing complex behavioral and emotional struggles. These past few months have been demanding being in the program, and especially considering the extremity of necessary as a direct care counselor, which is understandable. Just constantly being by the kids and adapting to each individual and sort of maintaining that earned trust has been one of the most rewarding, but also one of the most challenging things for me, considering factors such as trauma and their life experiences and upbringing, culture, race, and ethnicity. I would say diversification is absolutely vital to be able to provide the necessary support and individualized plan for these kids and working with them, which really I think echoes its indispensable significance. This is not to say that it's easy, and I myself have been faced with several periods of burnout. I know Eva and a lot of my peers, we've discussed this in many points with Mrs. Cohen during our breakout groups as well. So a lot of uneven workloads and just disheartening realities that some of these kids have gone through. And this is just in Needham. So I'd imagine less affluent surrounding cities and towns to have similar, if not further exacerbated disparities, which just makes the journey seem even more out of reach. I'd also imagine this to be a barrier when building a diverse, inclusive team. I think one of my greatest aspirations lies within continual efforts of expanding accessibility to behavioral and mental health services globally, while continuing my education in pursuit of a psychiatry degree. Starting a nonprofit organization sort of designed in the Western world on the premise of countries, specifically within the Middle East, the Dominican Republic, and other third world countries where mental health isn't as well regarded or acknowledged. Often stigmatized language and beliefs about mental health issues run rampant, which is why why developing mental health care policies and actively promoting the system where better, more compassionate outcomes are the norm will serve better. So growing up in Lebanon, a tiny country in the Middle East bordering Syria and Palestine, I spent a lot of my childhood just witnessing the ongoing effects of trauma, abuse, and being uprooted from one's community. I would say that, sorry.
It's okay, Fatima. That's okay. Thank you. Thank you. Thank you so much for sharing your personal story with us. Thank you.
Yeah.
What do you hope to accomplish once you complete the program?
I'm hoping to just continue to dedicate a lot of my efforts into becoming a more culturally competent and inclusive and aware individual, and just work towards my goal of becoming a psychiatrist, as well as working on the nonprofit organization that I hope to kickstart in the future. Yeah.
Thank you. Thank you for sharing that heartfelt story. Ms. Evelyn, would you take us home?
Sure, Mark. Good morning, everyone. As Mark or Mr. Abelard introduced, my name is Evelyn Monks. I use she, her, hers. I am grateful to have the opportunity to speak with you all today. I would like to thank Mr. Abelard and Dr. St. Louis for graciously allowing me to share my wonderful experience with the Behavioral Health Service Corps. I'll start by sharing a little bit about myself. I just graduated from St. Joseph's University in Philadelphia this past May via Zoom graduation ceremony. I received my degree in interdisciplinary health service with a minor in psychology in my dining room with streamers, balloons. My mom gave a speech. My dad handed me my diploma. It was great. At the time of my graduation, it was my plan to work for a year before continuing my education. But the global pandemic put me on a different path. While researching graduate programs, William James College was among my top choices. As we looked deeper into the WJC website, I cannot take credit for this. My mom actually was the one who discovered the Behavioral Health Service Corps. This program appealed to me for a myriad of reasons. When I called to find out if they were still accepting applicants, I was thrilled to hear that they still had open enrollment open. Without delay, I went straight to my laptop to resume working on my application and submitted it as soon as I could. This program really appealed to me because it offered everything I needed at the time. Coursework in psychology, on-the-job experience, professional mentors, and of course, a paycheck with benefits, which to a 22-year-old is a huge deal. I needed more clinical work experience because all of my prior experience took place in a medical office setting. When I was younger, I believed I wanted to be a medical doctor, but after my first year as a biology major, it was clear that that was not the path for me. Over the course of my years of education and extracurricular activities, I've participated in no small number of icebreakers. You all know the ones where they ask you to say your name and a word that describes yourself using the same word, the same letter of the first letter of your name. Mine was always extroverted Evelyn. It was clear to me that I belonged in a people-centered field. The shift towards working in the field of psychology seemed the most logical step because I was interested in an environment that would include more one-on-one interaction with people. The Behavioral Health Service Corps would allow me to dip my foot in the water of the behavioral health field. As a newly graduated student, the exact path to take was not immediately clear to me, but I was open to trying new experiences to see which or which not would not be the best fit for me. In addition, the Behavioral Health Service Corps provided me with educational opportunities that dovetail perfectly with the clinical work I would be doing. William James set me up with an interview with Walden Behavioral Care. One of the key points I distinctly remember from the conversation during my interview is how important it is to balance both school and work. As a candidate, I felt I had the advantage because I was able to bring the insights that I learned in the classroom to the work I'd be doing with the clients. In addition, my interviewer explained to me that working in the clinical setting would complement my classwork because it is difficult to understand some clinical precepts from a book. They must be learned in firsthand experience to be better understood. For those of you who are not familiar with Walden Behavioral Care, they are a comprehensive eating disorder center that focuses on recovery through multiple levels of care. I'm currently at the residential level, where we are a 24-hour facility, but we're not their highest level of care. At Walden, my title is Mental Health Counselor. My day-to-day responsibilities include checking in with residents, where I take about 10 to 15 minutes to see what they need, whether it be a sounding board, a set of ears just to listen, or to provide support with coping skills that they can utilize. I also meal coach which is where during meals I'll take time to just kind of make the environment more comfortable and less stressful for those who kind of fear eating and fear that kind of setting. In addition, I also facilitate educational groups. Some of the groups I run are self-care groups. Some of them are like CBT education. Others are on implications of eating disorders. They're all very interesting. And I even learned stuff from them, which has been really helpful in my growth and development as a professional. In my time at Walden, there have been abundant opportunities for learning about the mental health field. In addition to coordinating employment for me, the Behavioral Health Service Corps has provided me with a mentor who is a student at William James College. It has been beneficial to be able to get advice from someone who already has experience in the field. In my most recent meetings with my mentor, Jenny, we have been discussing how to pursue my future career. She has helped me provide me with education about graduate programs and give feedback on my applications. In the future, I would like to pursue the PsyD program at William James with the concentration in health psychology, because I would believe it would blend my background in the health field and my passion for psychology. To me, health incorporates both physical and mental health. I'm excited to be moving forward with my career and aspirations in hopes of one day becoming Dr. Evelyn Monk's PsyD. Thank you.
And so with that, I believe we have an obligation to do all that we can to help these three young people achieve their lifelong goals. And so we're hoping with the Behavioral Health Service Corps that we're helping to help diversify the behavioral health service field and give you a snapshot to what the future leaders in behavioral health would look like. Dr. St. Louis.
Thank you, Mr. Abelard, and thank you to our student panels. I'm so moved by your compelling narrative. And I think certainly your presentation today speaks to the importance of ensuring that when we organize these types of gatherings, that the voices and the faces of our students need to be represented because it is for you that we are building these wonderful training opportunities, and to hear certainly what impacts these programs have had on you personally and professionally. That's very rewarding to me. So thank you very much, Eva, thank you, Evelyn, and thank you, Fatima, for sharing this moving and powerful narrative with us today. And thank you also to Dr. De Olympia for providing an overview of the structure that really has led to the establishment of the Behavioral Health Service Corps. I would like to take a few minutes to see if our attendees would like to ask any questions of our student panelists. You don't have to be shy. You're in good company. We're all friends here. Any questions or comments for our panel?
I have a question.
Excellent. Thank you, Shawnee. I know you always have questions. Good questions, too.
I am curious as a cat. So yes, I always have questions. For the young people who are in the Behavioral Health Service Corps program, Eva and Fatima, your stories highlighted for me the importance of what we call support. What kinds of things do we have to rethink in order to be truly supportive of you, allow you to bring your full self to the table, including difficult experiences that you touched on? What do we need to rethink when we think about supervision, when we think about leadership, when we think about mentoring? What's missing for you?
I can comment on that. I guess I don't really feel as though anything is missing from my supervision, but I enjoy getting to talk about things on a weekly basis with my supervisors. So even just that 5 minutes that I have with my supervisors before speaking about persons on my caseload or speaking with Ms. Cohen about our academic week, just that 5-minute check-in at the beginning to make sure that we feel as though we're on the right track and feel safe with our clients and feel comfortable with the work that we're doing is really, really great. So I think allowing students, allowing people of whom you supervise to just have that open and honest space to communicate their thoughts and feelings is really great.
Oh yeah, I completely agree with Eva. I think collaboration is critical in a lot of these roles and positions, especially in a field where burnout is so prominent, I think, because of the type of work being done and the type of like directness, really. So yeah, just collaboration and fostering that environment where, that accepting environment where there is a chance to sort of openly discuss everything, especially where it's just like work, work, work. Like you need time to process that in order to sort of refine your goals or the future that you're sort of working towards, rather than just work, 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 and then burnout, and then just being blinded by that and sort of blindsided.
Oh, I want to add one more thing, actually. I think something that's really important that I'd like to highlight from both BHSC supervision and my clinical supervision is teaching boundaries to new persons in the field, having that work-life balance, understanding what topics are unnecessary for clients to be asking you about, and really just building that like personal and professional boundary feels really important to help with burnout.
This is Lillian. I have a question. This is mainly for Fatima. I was just wondering, how do you navigate the conflict between what you're learning in your studies right now that might be very different from your cultural values, because you did mention a bit about what you're studying, and a lot of what we learn in our psychology and all that is based in Western values, and I was wondering how you navigate that and how you navigate that. And then the second one is for all of you students, what do you do for self-care? What do you do for self-care, and have you developed a culture of, a practice of self-care before you actually get into the field, where a lot of us will be telling you should have learned your self-care back then. So, all right, I'll stop there.
Yeah, I think, thank you. Those are great, great questions. And to be quite honest, it's hard. It's really, especially growing up somewhere so far from where I'm sort of just learning everything. It's difficult to sort of relate back to my childhood and be like, well, this directly negates like what I was brought up on or what I was thought to have stood by, like in such solidarity. So it's definitely difficult to reflect on that and be able to open myself completely to what I'm learning. I would say there are still hesitations, and I don't really, I just see it as a continuous process. Like who I am is someone that is going to be changing as time goes on, and the more I learn, and I see it as more of I see it in a different lens. is not like, oh, change is so, change is like unhealthy or this is not who I am. You know, I see it as sort of a growth mindset where I'm in pursuit of something that I truly want. You know, it's about my authentic self. It's not about what was sort of implanted or bestowed upon me. It's how I sort of reimagined it. So it's definitely a continual effort, and you know, who I am is constantly changing for the better, I'd like to say. I'd like to think. So who I am is definitely becoming clearer, and I'm just going to keep working on that. And as for self-care, just spending time either alone, sometimes alone, and sometimes just with genuine people. I think that's really important to sort of unwind and kind of reset, especially when working in the behavioral health field, just because there's so many stories and I work with kids, so a lot of just difficult things to sort of grapple with. You know, it's really heartbreaking. So taking care of yourself is really important, and exercise and eating well, sleep.
I love it. Thank you.
It's simple, but it is hard to sort of apply.
I can imagine. Thank you. Thank you.
Thank you.
Evelyn, you've been pretty quiet throughout. Would you mind commenting to some of your self-care techniques that you've been applying since you've been in the program?
Of course. I think from day one, even during in orientation, I remember we did like a whole day kind of on self-care, and like kind of to Eva's point of boundaries, that's actually a really big form of self-care, being sure like you know where your limits are so you don't kind of overextend yourself. And some other self-care practices I do, making sure I get like the right sleep to the best of my ability. Sometimes there are things where you can't quite make that work, but also exercise. I personally really like to do yoga. For me, that's a really big self-care, and just taking time away and just sitting by myself or talking with loved ones like via Zoom or FaceTime. Sometimes it's just what you need to decompress and give back to yourself so you can give back to others.
And Eva, would you like to share some of your self-care?
Yes, I recently adopted a new cat, a quarantine kitty, as people put it. So that's been a lot of my time and care, and she is actually currently trying to scratch under my door right now. So a lot of my care comes from getting to care for another little critter.
Excellent. Well, thank you again to our student panels and Mark Abelard and Jenny D'Olympia.